What's up, everyone? My name's Hunter. I'm a real-life emergency medicine resident. Let's react to the PITT.
Cellulitis on the dorsum of the foot, now spreading up the leg.
Hello, I'm Dr. Robbie. Mind if I take a look?
How long do you think this is going to take? I took an early lunch break.
I don't know that you're going to make it back to work today. Erythema and warmth halfway up her knee. When did you see her, Donnie?
This is our patient from the previous episode who had what they thought was a cellulitis, so they drew a marker around the area that was inflamed already, and then she came back because the rash had spread outside of that border. And now she's having pain out of proportion. I wouldn't be surprised if this turned into a necrotizing soft tissue infection or something that needed surgery on top of the IV antibiotics that they're already proposing.
Santos, you want in on trauma too?
Too much charting, too little time. 62-year-old male presents with chief complaint of left lower back pain. Consider the diagnosis. Jesus Christ. I'm charting.
Sorry. Did I do something wrong?
Besides interrupting me, probably.
Then I apologize. I know that second year of residency can be stressful, so if there's anything I can do to help you. Like stop talking?
That's a great idea.
Yeah.
Consider the diagnosis of aortic aneurysm or dissection.
Got a new one for you in third chain.
I'm 20 charts behind, and the new attending is threatening to make me repeat a year if I can't catch up.
Crimea River, old lady with bad abdominal pain. Somebody's got to see her.
Dana, please do me a solid.
Holiday weekend. Westbridge is down in our waiting rooms on overdrive. I'm sorry, but your charting's going to have to wait until after your shift.
This is something that's super common in emergency medicine. The thing that we despise the most is our charting and writing the notes for the encounters that we have with patients, but it is super important, and it can be really frustrating when we're trying to get through a task and get interrupted, but that is just part of emergency medicine and what we signed up for. It's a job that is constantly changing pace, and you're changing your mindset when you're thinking about different patients, and oftentimes you get interrupted doing what you feel is most important at the time, and sometimes those interruptions are really important and shift you into a different mindset to see someone that is more acute. So I understand the frustrations, but it's also just part of the job that we signed up for.
Hanging Vanco.
What's Vanco?
And also lactic acid, CRP, and calcitonin.
She's not febrile, not tachycardic, no evidence of SIRS.
Yep.
What's SIRS?
Systemic inflammatory response syndrome.
This is kind of an example of using a lot of medical speak in front of the patient. It's often best to use lay terms. I get that they're talking to each other, but this patient is very much awake, alert, and listening to their conversation, so they should be including the patient in that conversation. But basically, they're talking about whether or not the patient has signs of sepsis. SIRS are kind of the criteria, or a systemic inflammatory response. But they're saying the patient's not tachycardic or febrile or hypotensive or showing other signs of end organ damage, like kidney failure would be shown in labs. If they had an altered mental status, you can have bumps in liver enzymes that show an acute liver injury. All of these would suggest that the patient is experiencing some form of sepsis, whether it be sepsis, severe sepsis, or septic shock. And all of the labs that they mentioned are how you would work up sepsis and treat it. That being the blood cultures, the basic electrolyte panel, the CBC looking at blood counts, as well as a lactate, which will be elevated in sepsis, as well as other things.
Hypoactive bowel sounds, soft with moderate tenderness in the left lower quadrant. Mrs. Randolph, do you take Percocet every day?
No.
Huh. And what about your water intake?
Pause. Mrs. Randolph, you said you don't take Percocet every day, but when was the last time you took some?
Maybe 3 or 4 times last week. Assisted living had a ballroom dance competition, and I tweaked my back.
Any further questions, Ogilvy?
When was your last bowel movement?
I don't know, sometime last week. I've been stopped up for at least 5 or 6 days.
Painkillers can cause constipation.
I know. That's why they put me on a stool softener, and then they tried an enema.
And no movement.
Sip. And then they gave me this horrible drink.
Mag citrate.
Yeah, mag citrate. Made me puke.
All right, what's next, Ogilvy?
Let's get you an x-ray and see how we can help you, Mrs. Randolph.
Thank you.
Differential?
Probable stool impaction, but with her history of cholecystectomy, it could be small bowel obstruction.
Or worse?
Sigmoid volvulus? But that's a surgical emergency. Wouldn't you have tons of pain?
Not always, especially when you're in your 80s.
This is one of the first things that I learned on one of my shifts as an intern. It wasn't that I had a patient with like a crazy outcome or anything like that, but I was doing a presentation on a patient to one of my attendings, and we were talking about whether to get abdominal imaging, and his teaching to me was that the elderly abdomen lies. And that's just that you can do a physical exam and the abdomen be completely non-tender and there still be a very significant pathology going on. So we tend to err on the side of getting additional tests, whether that be labs or imaging, in elderly patients, especially because A, their body doesn't respond to a lot of the pathologies as we would expect them to, and B, when we talk about limiting radiation with x-rays or CT scans, we're talking more about the younger population that is going to be subjected to more of it across their lifetime. When someone is already in their 80s, the radiation that they're going to experience from these tests is very little, and their body won't have the time to produce a cancer due to that radiation. So we have a much lower threshold to get imaging in the elderly population.
I am getting concerned. This is a millimeter past the line.
Or my line was sloppy.
Any increase in pain? Oh. Okay, sorry. Let's try morphine.
White count's only 10,000. It'd be over 12 for SIRS.
There are other criteria.
Still afebrile.
Did you ask about past history of MRSA?
Not specifically, but she's never been hospitalized.
Any evidence of an immunocompromised state?
No, she's healthy.
Steroid use?
Never.
Maximum heart rate's only 89.
Is that okay?
That's good. Very good.
Stay with her. Monitor her closely. If there's any change in her condition, come find me. I mean, any change.
I mean, at this point, I already know that this patient is coming into the hospital, so I'm consulting internal medicine to get them admitted. I don't know the status of their bed situation in the hospital, but my guess is that the internal medicine physician would come see this patient, see what's going on, and then they're going to be like, I want surgery consulted because I'm concerned that this is a much worse infection than what we can see. And then general surgery might have something to do with them in the OR, but this is something that needs to be caught early, and by waiting our time and just seeing how things progress, we're delaying the time to the definitive treatment, which my guess is in this case is going to be debridement of whatever infection this is.
Haven't seen you guys in a hot minute.
Pick up from SCI Jones Forge. Supposed to go to Westbridge, but got diverted to you.
Yeah, you and everybody else.
Princess, I need you to pivot to Central 9. Got it.
Gus Varney, 54, victim of assault with diffuse blunt trauma. He's got bruising to the face, the right chest, 10-centimeter lacerations to the left arm. BP's 136/84, pulse 102, good sats, 95 on Romero.
How you feeling there, Mr. Varney?
Fucking hurts.
Where?
Everywhere.
I am Dr. Robbie. This is Dr. Alashimi.
We'll get you something for the pain.
I've got a progressing cellulitis.
Go, I'm good.
Thank you.
Gus, do you know who hurt you?
One of the fine, upstanding citizens of cell block 6.
It's a deep lack through the muscle fascia. Can we get the cuffs off once he settles?
Not a chance. Orange jumpsuit, he's cuffed for a reason.
Let's go.
Okay, everyone, on my count. 1, 2.
Hold on. Go.
1, 2, 3.
Mel, E fast. Whitaker, primary assessment.
On it.
Oh, weird bruise. Did he fall on something?
Footprint. Got stomped.
Jesus.
Is that necessary?
Afraid so.
The airway's patent.
Good lung sliding on the left. Ah! Sorry. Good on the right, too.
How are the lungs?
Good breath sounds. No crepitus.
No effusion.
Pulse ox 97, BP 118/78, heart rate 112.
Tachycardic from the pain.
Start with 4 of morphine, repeat PRN.
On it.
Okay, swollen mandible. Open your mouth for me, Gus. Little wider. Can't.
Whitaker, you know the tongue blade exam?
Yeah.
It's a great test for a mandible fracture.
Gus, bite down hard on this for me. Sorry, Gus.
So they didn't really show it, but the tongue blade exam, they put literally a popsicle stick, a tongue blade, into the mouth and have them bite down. And then if you twist the blade, the mandible will shift if there is a fracture. And so it's a very good way to pick up a fracture if the patient isn't able to open their mouth, whether they're in a C-collar or just due to pain. There's a lot of things going on with this one, so I wanted to pause and talk about it. But we oftentimes see patients that come in custody, whether there was an assault in the corrections facility and we are evaluating them as a trauma patient, or just people coming in with regular medical problems. You know, we have inmates coming in with abdominal pain and high blood pressure, headaches, like anything that a person out in civilization can have can also happen in jail. And so we see patients in custody all the time, and sometimes the corrections officers that are with the patients can get in the way of patient care, and these patients deserve the same treatment that everyone else does. So we are often asking officers to step outside of the room to give the patient privacy. In this case, like, I don't know what the circumstances are that this patient is cuffed with ankles and wrists. They might be a very dangerous person, but there's often security measures in place where we have our hospital security guards working in conjunction with the corrections officers to be able to give the patient the care that they deserve while keeping everybody safe at the same time. So there's obviously different things that we don't know about this case, but the fact that they're like so quick to handcuff the patient, even though we're trying to get a good exam, I would err on the side of like releasing some things as long as we have the personnel necessary to subdue the patient should we need to. But this patient needs to get a very full assessment. I mean, we're finding bruises, cuts, things that can't be seen unless we do a very thorough exam. And having the patient completely restrained is only slowing that process down.
Cycling the BP. Okay, this redness is now a centimeter over that line, and this might be Ebola forming.
Vancomycin takes a little time to work.
Vital signs are still stable, 122/78. I got it.
They should have probably also started some clindamycin.
I'm feeling a little warm.
That can happen with Vanco.
Thanks, man. Lactic acid 4.2.
Okay.
4.2 is elevated.
Can be a sign of a more serious infection, but the good news is we know what to do. Jesse, 2 liters of LR wide open.
They're really slow playing this case. Like, we should be getting consultants involved and like starting things.
Okay, I got it. Thanks. Jesse, 1 gram meropenem, 900 milligrams Clinda, and page Dr. Garcia, please.
There's the Clinda.
We're adding new antibiotics.
It's serious.
We want to get ahead of it and make sure it doesn't become serious.
If you like the content you're seeing, I am a first-year resident in Minnesota doing emergency medicine, and I've been documenting every day of my residency journey, and I have a link to the playlist in the description below.
Considered the diagnosis of aortic aneurysm or dissection, but the point of care ultrasound was
Done with that good luck, Granny?
ordered an acute abdominal series to rule out obstruction, still waiting on the x-ray.
Great, then you're free to treat our latest and greatest in SAS 16.
Oh, come on, Dee. It's like every time I get a moment to chart, I barely get a sentence out before I get
interrupted. Sucks to be you, but trust me, it sucks worse for the poor gal in 16.
I'm beginning to think you enjoy torturing me.
Perks of the job.
I'm sorry.
Me too.
Sorry. You have kids?
2 boys, 15 and 9.
My son's 12.
Goes fast. Too fast.
Swelling and bruising over the distal tibia. 50 of fentanyl, which is naloxone per 100. What do you usually take for pain?
MS Contin, 30 milligrams twice a day, oxycodone for breakthrough, and sublingual Actic for when it gets really bad.
That's a lot. You end up.
This is a great question that I love to ask patients because patients know their pain better than we do when we're meeting them for the first time. And I know that there's this like stigma about patients are always seeking for drugs, and that is just like not really the case a whole lot of the time. 99% of the time, patients are actually having pain, and it's our job to treat it. And some patients, especially cancer patients, have very intense pain regimens that they use opioid medications as well as other adjuncts to control their pain that they get from their cancer. And when they present to the emergency department, they've taken their normal pain meds, and it's our job to recognize that and give them enough medication to temporize their pain, because they're much more tolerant of these drugs than the general person out on the street.
A hospice nurse comes by a few times a week, but I was alone when she had the seizure. They told us that it could happen, but she couldn't breathe. I freaked out. I called 911.
So sorry.
I'm sorry. I'm sorry.
I think there's another common misconception that was highlighted right there, which is that people believe that hospice just means you're left to die, and that is just not the case at all. There are varying levels of hospice, and typically when a patient is on hospice, they do have different levels of care that are allowed, and it's kind of dependent on insurance, how things are being paid for, as well as what the patient's wishes are. But if a patient is on hospice and they develop some random acute illness that is different from the chronic illness that is slowly taking their life, they are very much able to get treatment for those things so that they can continue to live within the bounds of whatever their terminal illness is.
Due to your family income, you make too much to be eligible for either Penny or the hospital's charity care.
But we can't afford health care premiums.
It's unfortunately very common for people to fall between the cracks. It's an imperfect system.
Can PTMC help with the cost in any way?
We can offer financial assistance. You'd pay the same that Medicare or Medicaid would pay.
How much is that?
You pay 60%, we cover 40%.
Thank you. Where have you been?
How are you doing?
I'm sorry, Mijita. You were being thoughtful. I just blew up.
Well, Miss Noel was just telling us that the hospital is gonna give us a big discount.
We can knock 40% off your final bill.
That's great.
I stay here for a few days. My bill could be over 100,000, right?
Yes, unfortunately. It could end up being lower depending on your level of needed care.
Or higher. So we would still have to pay 60,000, which we don't have.
He has to stay here to get better, right?
Yes.
No. Excuse me?
I mean, not necessarily. Couldn't we just admit him to med-surg instead of ICU? Wouldn't that be a lot cheaper?
Med-surg won't accept him with an insulin drip.
Usually true, but let me talk to the charge nurse upstairs, and I'll see what she says.
This is very true that patients get accepted to different levels of care within the hospital based on the treatments that they're receiving, and it's quite frequent that any patient that is on a titratable drip, and in this case it's insulin, ends up in the ICU. And that's just because the nurse to patient ratio is much smaller, so that they're able to receive more frequent checks. The nurse is able to pay closer attention to what these drips are doing and how the patient is responding to them. And there are studies coming out now that in patients with DKA, we can start subcutaneous insulin much quicker, and perhaps doing that instead of going up to the floor on a drip would help to prevent this patient from an ICU stay.
I considered the diagnosis of Cotta-Aquinas syndrome, but the motor and sensory exam were both intact in the
Our unhoused coffer has pneumonia.
I'm cursed, fucking cursed.
It's hard to see exactly what Dr. Santos is doing here, but every time that they come back to these clips of her documenting, it sounds like she's documenting what is called the MDM, which is a very important part of our emergency medicine notes. And basically, it's our narrative of exactly what happened within the person's ED stay. So we are talking about like very basic initial presentation, what we interpret of their vitals, what our differential is a big thing, and then how we ruled out the different parts of our differential and came to the conclusion that they are ready to be admitted versus safe to discharge home. And it's really important that we, get this medical decision-making part of the note very accurate and in this case, done in time, where she's 20 charts behind. But I can see how it'd be frustrating to be in her position, but we are taught to be very on top of our notes and get them done as we go, so that at the end of the shift, we're not sitting there trying to get 20 notes done, trying to remember the person that we saw 8 hours ago.
That is a cavitary lesion in the right upper lobe. Active TB.
Tuberculosis.
AFB stain to confirm. Move her to a negative airflow room. Start her on meds.
Call infection control and public health, and now you get to sign in as a patient and get your blood drawn for a quantiferin gold.
It's too soon to be positive.
Yeah, but you were exposed. You need a baseline test, and then again in 8 weeks to see if you convert.
And if I do?
Then meds every day for 3 or 4 months with regular blood tests to check for toxicity.
Jesus.
All right, let Dana know what's up, and for the love of God, mask up when you move her.
Head and neck CT is negative except for mandible fracture.
Okay, let's get him off the board.
Roll him right side out.
Hey, we're gonna need the cuffs off.
Ready? And 1, 2, 3. Gentle. Dr. King, how are the chest and belly?
We have 3 anterior rib fractures and a small pulmonary contusion.
Not too bad. When do pulmonary contusions peak?
After a few hours.
And do we always admit for a 3-rib fracture?
In the elderly, yes, but not if a patient can manage the pain and doesn't need supplemental oxygen.
Good.
Okay, he's really hurting here. You think you could set us up with a serratus anterior field block?
No problem.
Oh, as long as that's okay with Dr. Al-Hashimi.
If the patient consents.
Mr. Varney, we want to give you a shot to numb your broken ribs so you can breathe easier.
A common problem with rib fractures is that people tend to splint their breathing because it's very painful. Every time you breathe, your ribs are moving, and if you have fractures in those ribs, it's super painful. But when you splint your breathing, you're at risk of atelectasis or parts of your lung collapsing because it's not fully expanding, and then that can cause you to get hypoxic and cause many other problems. And so what they're talking about here, I really liked how Dr. Whitaker put it in very simple to understand layperson terms, a shot to help numb up your ribs. And basically what they're going to do is put a injection of a anesthetic near the nerves that would innervate those ribs and reduce a lot of the pain. We're actually, at least at my hospital, doing fewer of these serratus anterior blocks. The serratus anterior is the muscle that kind of comes through right here. I'll have a diagram on the screen. They call it the boxer's muscle because it's very pronounced in people that box for sport. But we're doing a lot more erector spinae blocks, which are more of a plain block that is done in the back and gives better coverage to the whole rib cage.
Do you need to get that?
Nope, it's my mom. Ignore it, just ignore it.
Amen, sister.
Forearm is numb. We can irrigate.
If I ignore a problem for long enough, it just goes away, right?
I wish I could ignore my deposition.
That you can't ignore, but you'll be fine. What's up with you, Whitaker? Trouble in rooming land?
No, not really. I think I overstepped with Dr. Langdon earlier.
Oh.
He was trying to prescribe a patient benzos, and I told Langdon that it'd be better if I did it.
Oof.
Only because I was already the assigned physician. But yeah, now I feel like an asshole.
Langdon's fine. He went to rehab, he's working the steps, and hopefully it's all behind him.
This is another one of those cases, like, I will say, there is a lot of gossip that happens in the emergency department, but doing it in front of a patient, especially a patient that's awake, is like, we just should not be doing that. Like, not around patients at all, but especially when patients are listening to what's going on with other doctors and this drama. Like, it's not good for patient care, not good for the reputation of the other physicians involved. So we just should not be engaging in it.
How are we doing in here?
Spiked attempt to 102, gave Tylenol.
Check out her leg. That is a definite bulla. Did surgery come down yet?
Not yet.
I need surgery.
I never heard that they consulted surgery.
Last resort. We would like them to come down and check out your leg in case we need to remove this infected skin.
I thought it was just a little swelling because I'm on my feet all day.
Open shoulder dislocation is back.
Westbridge shut down all their ORs, so they told us to bring him back here.
You joking? This ain't the Radisson?
Not my problem. Where should we park him?
Grab a wall.
On the well, call ortho, call the OR, tell me we got a patient back that needs surgery and admission. Hey, so sorry about this ambulance tour of Allegheny County, Mr. Billings, but we got you from here, I promise.
Yeah, I'm starving. Is there any way I can get something to eat?
Sorry, not before.
Absolutely not.
Sorry, got backed up.
Sounds a little wet.
Someone asked for surgical
Yeah,
consult?
that's because of all the fluid. Here are the lines for now.
And settings 50% tidal volume 500 AC 12.
Yep, that's perfect.
Surgery here. Hello?
Hey, it's about time. Where's Garcia?
Stuck in the OR. She sent me down. What you got?
Septic shock, respiratory failure, and possible necrotizing fasciitis. She needs to go to the OR ASAP. The infection was isolated at the dorsum of the foot 5 hours ago, but now we're almost to the knee with bullous crevitis and edema. You seen neck fascia before?
In a textbook. I was a med student 2 weeks ago. Gotta show this to Dr. Garcia.
Okay, Jesus Christ. Go get anybody else from your service down here. Shamsi, Miller, Walsh.
I don't know any of those people,
Don't take
but-
this personally. I just need a fucking grown-up down here.
I think that's very common where it is very common where the intern or the first-year resident will be the first one to respond to a consult. It's the way that we really get good experience in seeing all pathologies, and then typically you would see the patient, start your note, tell your senior resident about it, and then the senior resident would present it to the attending, and then you kind of implement your plan from there. But there are certain situations that are true emergencies where we kind of just need to go up the chain and go straight to an attending because this patient needs to be in the OR like 5 hours ago. And so bypassing the intern to get to the people that make the decisions is pretty warranted in this case.
The patient's symptoms are consistent with lumbar radiculopathy at L4, L5, most likely due to disc herniation.
Coughing patient admitted to isolation for verified medication administration and started on right therapy.
Yeah, why do I even bother? Just fail me now. Okay. Get in touch with a social worker. They're going to want to do contact tracing and help her figure out transitional housing for when she's discharged.
Got it.
And make sure infection control responded. The people in the waiting room could have been exposed. They need to be notified and tested.
Okay.
Relax. You can take the mask off. You don't have TB. At least not yet.
Oh, great. This is fucked up. How are you so calm?
Expected job hazard. Get used to it.
Yeah, no thanks.
70% of doctors in training at urban hospitals get exposed to TB and wind up on meds.
Jesus.
Mm-hmm.
They don't teach you that in med school.
Mrs. Randolph's back.
There's a lot that they don't teach you in med school. We learn on the job.
Volvulus, no air fluid levels.
What do you think of this?
Fecal material?
A shit ton. Sorry, had to be said.
So what, she needs an enema?
No, tried and failed, remember?
Yeah.
Time to dig in.
How are we gonna do that?
Oh, there's no we in disimpaction.
Morphine PCA looks ready to go. This should do the trick. Do you notice a difference?
Better.
Oh, great. Great.
How does this thing work?
There's a baseline rate of morphine, and if you're having pain, you can push this button, you'll get some extra. And you can push for another dose every 10 minutes if needed.
Your very own morphine butler.
Amazing.
She can go home with this?
Yeah. Though you'll need more equipment for the house now that she can't bear weight on her leg.
Okay, like what?
A wheelchair to go to the bathroom, a shower chair, wall bars if you don't already have them, and a hospital bed could be helpful too.
How do we get all that?
You don't. I do. I will get everything so that the two of you can get out of here and back to the kids at home.
Thank you.
I was feeling a little bit of tension in that scene, and I'm not sure that this is the case in this patient, but I think as physicians, we sometimes feel that, or just like think that whatever we say is the plan, is what the patient would want, and sometimes we need to address what the patient's wishes would be. I mean, I don't know what the case is with this patient, but often we are having palliative discussions and discussions of goals of care and how much someone wants to go through. There are other ways that we can go to comfort care and, limit medical interventions and the things that we're doing. And I wouldn't say that, having a wheelchair and handicap bars around the house are really like invasive medical interventions, but they may not be aligned with the patient's goals for the rest of her life. And so we have those hard conversations in the ED and help to facilitate discussions with the patient and their families about exactly what care they would want, regardless of what our recommendations are.
Mrs. Randolph, in order to prevent this from happening again, I think you need a better stool softener. You can try Miralax. Just a tablespoon with a big glass of water every morning should do the trick.
Okay. Oh, sorry.
Passing gas is good. Means we're making progress.
Does that mean that I can stop?
No, nope, keep going.
Okay, you might wanna.
Ah,
I was gonna say they should be wearing some facial protection,
much better.
but
Do me a favor, give me some 4x4s and some betadine.
Sorry, we're getting killed with transfers from Westbridge. Mesenteric ischemia, perforated bowel.
Got a hot one here.
Yeah, possible neck sash.
Possible.
Need CT with contrast to
This is
confirm.
spreading like wildfire. By the time you get your CT, it's going to be up to her waist. She's going to need a hemicorporectomy.
She needs a CT scan.
How about stainless steel scan?
For Christ's sake, Rabinovich. Robbie, what the fuck are you doing?
Oh,
that looks like some dishwater exudate to me.
Purulence. There's a gray appearance to the fascia, and in the OR, you'll see easy separation in the tissue planes.
When do you start your sabbatical?
Tomorrow.
Not a moment too soon.
Thanks for coming down.
I'm catching up on my charting as fast as I can.
Why don't you give my generative AI app a try? It's 30% more efficient, and providers report increased job satisfaction. And you'll rarely have to stay overtime to complete charts. Yeah?
I've discussed this in the past where my program is actually talking about bringing generative AI into the department, but I'm very accepting of having AI in medicine, but there needs to be a very careful implementation. And I think as residents, it's very important that we learn how to do things without AI because these things fail all the time and they won't always be available. So the discussions that we've had in our department is that once it does become available, it won't immediately be available to residents, and residents must meet certain competencies before they're able to utilize some of these nice tools. I don't know that we're there in this case.
Hey, ain't no way I was gonna let you miss Peter Aubrey's epic 4th of July party. Come on now, hey. Brought some brew.
You are the man.
Appreciate the bromance over here, but no food, because you might go into surgery, no beer, because we're a goddamn hospital.
Starting your sabbatical early?
I know.
Is he taking that to Louis?
Right now.
In the hospital?
As a parting gift.
How's it looking?
Good. The stair strips did the trick.
CT is ready.
We already scanned him.
Head and neck want thin cuts and a 3D reconstruction of the mandible before they decide if Mr. Varney needs surgery.
Have they even come down to examine him in person?
No, they must be backed up.
Or there's a July 4th sale at the BMW dealership.
Labs are back. Albumin's low, total protein's low. He also has megaloblastic anemia.
Malnutrition.
Probably jail cuisine. Whitaker, what labs should we add?
B12, folate, iron levels.
Good. We're gonna run some more tests, Mr. Varney. Hang in there.
I think a key part of this, often when patients are coming from jail, we receive like 0 medical records. The records that the jail has are very rudimentary. It's usually a paper chart that doesn't include a whole lot of information. I never heard them ask the patient anything about his health history. And again, these are patients that deserve the fair treatment that we give to every patient that comes through the doors. And I think having a simple discussion with this patient could reveal some very pertinent medical history that would influence his treatment moving forward.
You lose your pulse ox again, bud? Louis. Louis. He kept pulling off his pulse ox.
It's on. It's at 71.
Louis, wake up.
I might get the carotid.
I got the airway.
Hey, Perla, crash cart intubation tray, please.
I think it's kind of interesting. It's happened multiple times in this ED where they just call for one specific person and like they might get help, but it seems like they're always like running codes and running these very acute situations almost alone. I think every hospital has a pretty standardized procedure. If you're in the hospital, there's a button that you can push that is a code blue button. Overhead pages will go out and you will get 20 people into this room immediately. And in the emergency department, it's very similar, but usually you just yell like code blue this room and you're gonna have way more people than you need there at once. And in this case, we've got 2 docs and a nurse that are gonna be running this. It just doesn't quite feel right. Maybe a bonding moment for Dr. Robbie and Langdon. Well, that was another great episode of The PITT. I have fallen behind, but I'm hoping that my editing is continuing to improve. Let me know if there are any constructive criticism comments that you have down in the comments below. I would really appreciate the subscribe to see my future reaction videos as well as my vlogs as I go through residency. But it's been a good one. We'll catch you in the next one.